creating the pressure gradients that we know are what determine flow. So the forces for airflow are such that the pressure gradient is required, so atmospheric pressure remains constant. We talked about the fact that we cannot manipulate that. And so during the breathing cycle, what we manipulate is our alveolar pressure. And this is where Boyle's law comes into place. So that relationship that I was speaking about with pressure and volume is really Boyle's law. And Boyle's law says that pressure is inversely related to volume. So if I increase the volume, I'm going to decrease the pressure. And if I decrease the volume, I'm going to increase the pressure. And given this law and what we know about what's needed for the pressure gradients and airflow, we can then manipulate the size of the thoracic cavity to then manipulate the pressures. Okay, so we can change the alveolar pressure by simply changing the volume of the lungs, i.e. the alveoli, i.e. the thoracic cavity. Now, we also know from prior knowledge, given the principles of bulk flow here, that resistance to flow is brought about by radius size, that's one of the factors, and then viscosity, which in this case will be the presence or absence of mucus, okay? So if you have a cold and you have lots of mucus in your airway, then you're going to see a little bit more resistance to airflow given these bulk flow principles, right? And this equation should be very familiar to us at this point. This is representing our pressure gradient, and then these are representing impeding forces to flow, which can be the radius. Now the radius is fixed in terms of the airway for the most part, right? We have cartilage at the upper parts of the airway, but as we get lower into the respiratory tract, what did we say that we see instead of cartilage? Smooth muscle, yeah. So smooth muscle has that ability to be manipulated more so than the cartilage. So this is where we can actually change the radius of the respiratory airway and then change the resistance and then change the flow, the rates of flow. And this is what happens with asthma patients. So they have lots of inflammation of the airway where that smooth muscle becomes really inflamed and swollen. And so they have lots of resistance to flow, and that's what creates a difficulty breathing and so on. All right. Now, I'm going to give you a minute to write down this. It's quite a bit of text, and then we'll go on. Okay, so let's look at this. So the ideal gas law says that PV equals nRT, and the variables here are P being for the pressure of the gas, V being for the volume of the container in question, the volume of the container that's holding that gas. N is the number of gas particles in moles. Here we're speaking about oxygen, so the number of oxygen molecules. And then R is the universal gas constant. T is the temperature. Now, I'm not going to ask you to calculate anything here or to memorize this formula, but this is to explain how we get this relationship between pressure and volume. So if we're keeping N and T constant, right, the number of gas particles and the temperature of that container or of the particles themselves, we can manipulate the volume of a container, and then we can therefore influence the pressure of that gas. So here, what we see is that in this large container, we have X number of molecules, let's say they're oxygen molecules, and this is representing the set volume here and the set pressure. Now, if we make that container smaller, right, same number of gas particles, we make that container smaller, right, so the volume now decreases, what we see is that as a consequence, the pressure will increase. And this is what Boyle's law states. So Boyle's law is deduced from this ideal gas law, and that relationship says that if we increase the volume, we decrease the pressure, and if we decrease the pressure, we increase the volume, right? So they're inversely related, okay? So the determinants of intraalveolar pressure are going to be things like the number of air in the alveoli, right? Then how much air particles are in that alveoli, as well as the volume of alveoli that are being involved or that are involved in gas exchange. So again, pathologies like pneumonia or emphysema can remove a part of the lung that is actively involved in gas exchange. So what really determines our intraalveolar pressure is the air, as well as how many alveoli are actively involved in ventilation, okay? Cancer does that as well. Carcinomas can completely block some of the alveoli from participating. So the lungs expand when the alveolar volume increases, right? So when we stretch on those muscles, the diaphragm contracts and flattens out. The external intercostals, because of their nature and because of their location, they're studded along the ribs. When they contract, they actually pull the rib cage up and out. Right, so the diaphragm is dropping the inferior border of the thoracic cavity. The intercostals are pulling the rib cage up and out. And so we're increasing the volume in this cavity, and that decreases the pressure in the alveoli. Okay, really important. So this creates that pressure gradient that drives air down into our lungs, right? And the reverse is true. The lungs will then recoil, right? At the end of inspiration, the lungs will recoil on themselves. They'll become back to their natural shape somewhat. The volume decreases. Those muscles that we mentioned, they relax. So the diaphragm in its relaxed state, it's that nice dome shape. The external intercostals will relax, and that brings the thoracic cavity back to its state at rest, which increases the pressure. So if we decrease the volume, we increase the pressure. And again, this is what we want to facilitate that gradient. High pressure in the lungs, low pressure in the atmosphere, and that drives air out of the lungs and into the atmosphere, okay? So basically, it's a chain of events that we're seeing here. We manipulate the thoracic cavity, we manipulate the volume, manipulating the volume manipulates the pressure, and that creates the gradient to move air either in or out, depending on what direction we need, okay? All right, this illustration is really good in terms of the overall summary of everything that we've spoken about so far. So at the top here, this top panel, we can see inspiration being compared to expiration and basically the state of the alveoli in terms of the air molecules. In the second panel, we can see the actual pressures of the alveoli. So these are the relative pressures. And down here, we can see the intraalveolar pressure in terms of the graphical change. And then here we can see the volume, right? So the volume and the pressure and how those change. So we start off with inspiration. So we're starting from a place of rest, right? At rest, atmospheric pressure, 0, alveolar pressure, 0, no air is moving. And then we gradually increase that pressure, decrease that pressure by increasing the volume, right? So we expand our thoracic cavity by contracting the intercostals, the external intercostals, and contracting the diaphragm so it flattens out. And that increase in volume is what drops this pressure to -1, right? So from 0 to -1. Now, air rushes in according to this gradient, but this is not a fixed scenario. This is very malleable. This is changing. So as air rushes in, we're now losing our pressure gradient, right? Air is rushing in here, and that is changing this scenario in such a way that our intraalveolar pressure is now beginning to increase. And that is again playing into that equation that we talked about. So we need to keep the number of gas particles constant, which we're not doing here. We're increasing gas in the container, and so the pressure will naturally begin to slowly increase because air is coming in. Now, we get back to a state of rest, right? When alveolar pressure is once again equal to atmospheric pressure. That's that pause that you get in between inspiration and expiration where there's no air flowing. And then we begin the cycle again, but in the opposite direction. So the muscles that we talked about, diaphragm and the external intercostals, they now relax. That decreases the volume. And because we decrease the volume, what do we do to pressure? Increase the pressure. Yeah, so we increase the pressure. Now it goes back up to 1. And again, that is facilitating our gradient, higher pressure in the lungs, lower pressure in the atmosphere, and air moves out of the lungs. So we can see how the intraalveolar pressure is changing here with respiration. So it's not a fixed value, but it must stay within a certain relative proportion with regard to atmospheric pressure, as well as intrapleural pressure, right? We talked about the fact that intrapleural pressure should always be negative in terms of keeping the lungs inflated. Now at the bottom here, we can see the volume change. So as we're breathing, air comes into the lungs get full, and then we expire all that air and the lungs drop again. The volume drops again. Okay.